In kidney cancer, it's always been thought, well, this is one of those cancers is not a very good shedder, right? And with this test, we use the Signatera test with a 16-gene whole exome sequencing tumor-informed assay. We looked at 92 patients between two institutions, and we collaborated data on patients for treatment response monitoring and also longitudinal following when they were actually just on surveillance. And what we saw that in the metastatic population, you still do shed ctDNA in specific populations in kidney cancer, especially when the tumor burden is much higher, when we have higher risk organs of metastasis like liver metastasis, bone metastasis, et cetera. So it's actually true that we can detect ctDNA in the metastatic patients. I think we're going to get better at deeper sequencing, whole genome sequencing, to look even deeper in the perioperative setting. So the take-home point here is that you could monitor patients for treatment responses, whether you can follow the kinetics of the ctDNA from baseline, and then as they start their initial therapy, you can actually see that the kinetics follows very closely with the clinical outcomes. And if you are undetectable at baseline but have metastatic disease, we see that the progression-free survival is still associated with a longer PFS, and this might mean that low-shedding tumors are probably the more indolent ones, right? The one that more mimic the good risk RCC patients. But we are going to be doing more studies prospectively in clinical trials coming up at Vanderbilt, where we are looking to possibly de-escalate tyrosine kinase inhibitor treatment in patients that actually start ctDNA positive and clear their ctDNA along with having good responses in their CAT scans. So this will actually help patients feel more comfort that, hey, maybe I could stop my therapy and still not be compromising my safety.